Wonderful. It's great to be here. Galina, very nice to meet you over Zoom. I think there's two of your trainees also are on. You can stop me at any time. We can make it interactive. And my talk is going to be about renal trauma, kidney injury. And I'll share the screen with you. Can you see my screen?
Yes.
Perfect. I'm gonna. I think this is good, right? Perfect. So just to introduce myself, I'm Judith Hagedorn, and I'm originally from Germany. And then I came to the United States after my undergrad or my college or high school, actually, and for college. I went to the United States. My family all is still in Germany, but I've been in the United States now since 1998. And I did my training, all my medical training in the US. And with that also went to an IVUmed trip when I was a resident to the West Bank, which really formed my interest in reconstructive urology, because we brought the IVUmed attendings brought all their knowledge of reconstruction to the site. And I thought that was fascinating. And I also liked the surgeries and the thought process that goes into reconstruction. And so after finishing my urology training, I then did a subspecialty education in reconstruction and trauma. And you can, stop me anytime, but I'm located in Washington and Seattle, and I have two maps here. Maybe we can start with the top one here, where there's the red state, that's Alaska. Here, the United States, and we are bordering to Canada. So this is Canada, and Washington is right here, this blue state. And our trauma hospital is called Harborview Medical Center. And it's the only trauma center for the entire WWAMI region. And the WWAMI region is made out of Washington, Wyoming, Alaska, which is up here, but it's, depicted down here. So it's high up, Alaska, Montana, and Idaho. So it's a lot of states. So if someone gets injured in Alaska or in Idaho or Wyoming, they're injured badly enough, they usually come to our trauma center. And so we see a lot of injuries. We cover 214 lower level centers. So we support them. And if they have patients that need higher level of care, they send them to us. And so we see about 100 to 130 traumas a year. So my talk today will be on renal trauma, and we'll get into surgical management. But as we know, and I would love to know how you manage trauma, because there's a lot of management that is dictated by the staging of the injury, which I'm going to go into, and the imaging. And in my experience, some centers in Africa, they don't have the opportunity to get patients scanned, or they don't have a CT scanner. So most of your consults for renal trauma might be intraoperatively. So I would like, and we get that too with penetrating trauma. I have a case on that, but it would be wonderful to hear from you how you manage an intraoperative consult and what you look for, and whether or not you explore the kidney or not, and what you do for urine leak. But this is going to be a talk on how we manage our kidney traumas. So first, epidemiology. Traumatic injury is the leading cause of death in the US. And in the young patient population from 1 to 44 years. And the urologic organs are involved in about 10% of abdominal trauma. The kidney are injured with about 5% of trauma victims, so not that much overall. But for us in urology, it's the common injury to have a kidney injury rather than urethral, testicle, penile injury. And that's, of course, data from the US. So kidney injuries, we usually categorize them into two different mechanisms, either blunt injury that can happen with motor vehicle accidents, falls, or assaults, or someone hits somebody. And they are the most common, especially in the areas outside of the cities. We have seen more penetrating injuries recently with more gunshots, because we have a lot of more guns here, and there's very little regulations on guns. And so we see that quite a bit, especially in the last few years. We also have seen some stab wounds with knives that can be self-inflicted or due to an assault. And then it's really important with those penetrating injuries to check the wound location and potentially find out what kind of weapon was used, and if it was a high energy or low energy. And then with the penetrating injuries, especially gunshot wounds, you need to think about the blast effect, meaning that the bullet comes in and it's going to injure the tissue around, even though the tissue might not be missing, but there might be effect on the blood supply to the surrounding tissue. So we always make sure that we debride that area to healthy tissue before we then reconstruct. So when the patient comes to the emergency room, there are certain signs we look for. A flank hematoma, which I showed here, that's not so common, but it can definitely happen. I've seen that before when someone falls on the flank or gets a hit in that area, and you can see that big hematoma. And then most patients have blood in the urine, but that shouldn't be if they do not have blood in the urine, it shouldn't make you not worried about a kidney injury, because you could potentially have a complete ureteral avulsion, so there's no blood coming down. So it doesn't rule out kidney injury, but most of the patients who have a kidney injury have blood in the urine. And then tenderness on the area, and then rib fractures are common, since the rib is kind of protecting the kidney. And so if there's a mechanism of injury to the kidney, then under that lies if you injure the rib, then underneath is the kidney. And special consideration is, I think, that high energy mechanism. When we decide, should that patient go to the CT scanner, should we be worried? The mechanism of injury is important. If they fell off someone really, really high off a bridge, or if they just fell from standing, that's less likely to injure your kidney. Or if you had a really high speed motor vehicle accident, then you should get suspicious about a kidney injury. There are guidelines that have been established by the American Urologic Association. And I'm going to go through some of the guidelines throughout the talk. So their statement number 1 says that the clinicians in the United States should get a CT scan, computer tomography with contrast, to evaluate patients with blunt trauma and blood in their urine that's visible, or if they have shock, meaning a systolic blood pressure less than 90, and microscopic blood in their urine. So it's important to keep in mind. Usually in the US, we as urologists are not involved in the decision-making of getting imaging. That's usually done by the emergency room doctor or by the trauma surgeon. So usually the patients that we get consulted on already have the imaging. And so what kind of imaging should we get is I'm going to go in a little bit. We talked about that the mechanism is really important. So if there was a significant injury or mechanism, then you should get imaging. So this is a patient who is 30 years old, and he got assaulted with a baseball bat. Someone hit him in the flank area, stomach area. Otherwise healthy, and on exam he's stable, he is mentating well, and he has some bruising over his left upper quadrant, but otherwise normal exam. So his voided urine looks like there's some blood in it. So we asked the trainees, what's the next step? And there is a mechanism that you're worried about, right? So someone hit the patient and they have blood in the urine. So per guidelines, the next step in the US would be a CT scan to evaluate the patient's injury. And that's, again, what kind of imaging do we get? It's IV contrast. And for us, it's always important to make sure that the patient gets delayed images. So what kind of phases does this IV contrast have? It has an early arterial phase where we look for active bleeding. And then there's a chordomedullary phase that looks at the parenchyma that can show lacerations. And then the nephrogenic phase where the contrast gets excreted into the collecting system. And then the delayed phase where the contrast that was given is excreted by the collecting system down the ureter. And it's important to get that delayed phase, which the patient has to go back through the scanner again about 10, 20 minutes after the contrast is given, so that you can see if there's any leak of urine. And so I think that imaging is important. And then from that imaging, we then grade the injury. And you might have seen those kinds of pictures before. And the grading is based on the American Association for Surgery and Trauma society that has a grading for all organs. And so this grading system goes from 1 being a minor injury to 5. And I think those pictures are really nice. They describe what those grades are. There's a contusion, and then there is a hematoma that's contained. The grade 3s are the ones where there may be active bleeding, but still the hematoma is contained under Geroda's fascia. And then there is grade 4, where there's no more containing of the bleeding. So the bleeding can actually be a lot more because there's no more tamponading effect on that bleeding. And you see that grade 4 has a lot of its potpourri of all kinds of different injuries, which is not ideal. And I'm going to show you a few images where we highlight how we feel like that grade 4 may need to be, classified or redistributed. And some papers have come out from Dr. Meyer's group, who has been active in IVUmed. He has a multi-institutional study looking at renal trauma, and they found that it might be good to especially classify the segmental injuries. And I'm going to show you pictures of that. And then grade 5 injuries are the ones that have the shattered kidney, the devascularized kidney, where there's a complete disruption of the hilum, the avulsion, or the devascularized kidney where there's a thrombus and you lose the entire kidney. But again, I think the management of those are very different. The life-threatening injuries, if the renal hilum, where the vessels come in, gets disrupted, and that's where the kidney emergently has to come out, because if you wouldn't remove the kidney, the patient may bleed to death. So that's really, really the life-threatening injury, or the shattered kidney where there's so much bleeding from all the different segments of the kidney that the kidney needs to be removed. But then the thrombus, where you have a devascularized kidney where there's no more blood flow to the kidney, usually that doesn't impact the patient too much in the acute phase. Sure, they'll lose one kidney function completely, but in the acute phase, there's very little danger to the patient. So going on, next case, our patient is now a 35-year-old male who was brought in by the ambulance, and he had a motor vehicle accident. He is unstable, so imaging cannot be done because the patient's blood pressure is low. He's taken directly to the operating room, and usually that's also done by our trauma surgeons. And then what they find is a large right retroperineal hematoma. When they open the abdomen and no other injuries, the patient gets a lot of blood products and transiently is resuscitated. But then, what are the next steps? I'm not sure if you know, if you would get called in Burundi, or if you you know, have the trauma surgeons handle that. It would be great to hear now or after I'm done with the talk. So if you want to chime in, I'm happy to stop here for a second.
Those in the emergency will deal with this, will manage the case. Most probably they will just proceed with the nephrectomy.
Right.
Yes.
Galina, for us, most likely too, because there's very little time to stabilize the patient. So you know, it's rare that the urologists get called at the time. If we do, and I think the surgeons might not do this anymore, but the teaching is that you need to make sure that the other kidney is healthy, or you can't completely say that's healthy, but it's if it's uninjured. And I think our surgeons, our trauma surgeons, they do that by feel and just, you know, make sure that the other kidney roughly feels like it's intact. There's also this IV pyelogram, or is an X-ray study that is done where the anesthesiologist gives contrast IV, and then 10 minutes later, one X-ray is taken to make sure that that contralateral kidney, and you can see here, it's nicely excreted. It's like the delayed phase imaging where the contrast is excreted. Even you can even see the ureter coming down here. So you can be assured that that kidney is fine. I think it all depends on how stable the patient is. If the patient is unstable, there's an expanding hematoma retroperineally. I don't think there's time for it, because the patient would otherwise bleed to death. So if the patient only has one kidney, or that other one is damaged too, it just needs to come out because it's life-threatening. But if there's time, then it's always a good idea to assess the kidney that is not injured to make sure that it's working. And what would you do if it's not working? I think then you hope to fix the kidney that is injured. And of course, we all know from studies that if you explore a kidney, very rarely can you fix it with surgery. It's possible, but it really depends on the injury. I've seen kidneys where they were completely, you know, in half, where the collecting system was in one half and the vessels in the other half. So impossible to get that fixed, because the vasculature is a completely different area than the collecting system, and it needs to be removed. But I think if the contralateral kidney would be problematic and maybe not functional, maybe you try more deliberately to save that injured kidney. But overall, what we've done, not for this patient that we just talked about, because the patient is hemodynamically not stable, but usually non-invasive management is done for hemodynamically stable patients with kidney injury. We have watched a lot of patients, even with those high-grade injuries, grade 4 and 5 injuries, even with a shattered kidney, we can observe. And I'm going to go into a little later what we use kind of to judge whether or not someone can be observed or not. But now let's go through a few imaging CT scans that we get before if the patient is stable enough. So this is a grade 1 injury. You see the contusion where the red arrow is. We would not get any follow-up imaging. The patient, if that's the only injury, the patient can go home. There doesn't need to be any follow-up, no ultrasound, and patients do well after that. Grade 2 injury, you can see the hematoma around the injury right here, but still contained, so not very big. Again, same here, where the patient does not need to be observed. The patient could go home and does not need any follow-up. Now we get to the higher grade injuries where the laceration is bigger. And this is a renal trauma from a mountain bike accident. The patient fell and now has a laceration. And in the grade 3 injuries, you may have some active bleeding. So it's important to make sure that the hematocrit stays stable, but you can again observe them without needing any surgery. So now let's go into this potpourri of grade 4 injuries. I think that's really important to look at because the segmental injuries, meaning that there is a portion of the blood supply to the kidney that got knocked off either by thrombus or by a tear in the vessel, and there's a portion of the kidney that does not no longer perfused. It is basically dark and it's not functioning anymore. But that's a very different injury than if there's an active bleed, right? This just doesn't get blood supply, and probably after some time will atrophy. The portion of the kidney, if it doesn't regain blood supply, will get smaller. This patient does not need any intervention. And I bet you don't even know about it, except if you would do a CT scan. So those injuries are found by us doing the CT scan, but really don't require any intervention. And I think that's why there's a push toward getting that grade 4 injury, because the higher the grade, the more dangerous it should be for the patient, or should at least predict how much intervention someone needs. So that injury should be downgraded. Grade 4, the two that we are more interested in are the ones that have an active arterial bleed. Here you can see the contrast coming out into the hematoma on the right hand, and on the left hand, you can see the contrast is actually coming out of the collecting system. And how would we handle those two? The right one, where there's active bleeding, we would definitely check the hematocrit of the patient. And if that keeps on dropping, we might give some blood, but if it keeps on dropping, then the patient in our center goes to the interventional radiologists, who are able to go in through the arterial system and then coil that bleeding vessel, which spares the patient of needing to undergo surgery. So that has been able to save some of the kidney, because we know if we explore that, there's a high risk of removing the entire kidney. So the interventional radiologist and angioembolization has been very helpful in retaining kidney function on that side of injury. And then for the active urine leak, we know that about 80% of those heal on their own. So if someone has quite a large urine leak, we may re-image them 2 to 3 days later and see if it has gone away. If it hasn't gone away, we place a stent, and I'll have a little picture of that later. So this is another scenario that I wanted to bring up. It's the devascularized kidney, where the patient's kidney now doesn't have any more blood supply, and basically the patient has now a solitary kidney. And those patients do not need any intervention. That kidney cannot be revascularized to give it function again. That has been tried in the past, but has been not very successful. So I think we stay away from that and let the kidney atrophy over time. But again, there's not a lot of risk in the immediate acute presentation, because the patient is not bleeding. And that would be the shattered kidney, where there's a lot of hematoma around the area of the kidney. The kidney has been broken into pieces, and those are the ones that we really watch closely. They may need an operation, especially if the patient keeps on bleeding. Here again, a large hematoma retroperitoneally that we can see, and only a portion of the kidney lights up. So there have been studies, of course, looking at the grades and when an intervention is needed. And we know that grade 1s and 2s, as I told you earlier, they don't need any intervention. And even grade 3s very rarely will need a bleeding intervention, because usually the bleeding stops on its own. But then grade 4s and 5s have a higher risk of intervention with either surgery. And for us, a lot of patients go to the interventional radiologist to get embolized to stop bleeding, But if that doesn't work, then of course they go to the operating room and have a high risk of losing that kidney. So initially we observe the patients with renal parenchymal injury, and that all depends on how stable the patient is. If the patient is stable, we observe them. It doesn't matter if they have a shattered kidney. It doesn't matter if they have grade 3 injury. We observe them. And we only intervene if there's a change in their hemodynamics. And then we usually get a CT scan a few days later to check if their urine leak has healed, or if there's a complication like a fever or a flank pain or abdominal distension that can be explained. And then repeat imaging is important to double check on them. So what do we do if we find that persistent urine leak? Usually if we re-image the patient at 48, 72 hours, then, and we still see urine extravasation, we take them to the operating room, and with a scope, we look into their bladder, and usually we put some contrast up with that you can see on the left-hand side and do some x-rays. And you can see here the upper pole has the contrast leaking out. And to help the healing of all of this, if it hasn't resolved within 48, 72 hours, we put a little stent in. It has a curl on each side, and we put that up the ureter to facilitate drainage. And usually we also leave the catheter in the bladder to make sure there's no reflux up into the kidney. That would defeat the purpose of placing the stent. But so you have to place a stent and a catheter to completely drain the system and allow healing of that leak. And that's usually the case. And then we take the stent back out. So what happens if someone has a complication due to their urine leaking? And what can happen is they may have a big urine collection in the retroperitoneum that then gets infected. And usually we put first a stent. And then if that doesn't help, then we put a drain into that fluid collection. And that's done by the interventional radiologist, where they put a drain in to then drain the kidney in the urinoma. What about penetrating injuries? And we've seen them more recently. And I think we still try to manage them conservatively, meaning without an operation, if possible. So if the patient is stable, if there is a low energy mechanism, low velocity, or a stab wound, then most of them can be managed non-operatively. And we also know that 50% of the stab wounds and 40% of the gunshot wounds can be managed conservatively. Sometimes we get called to the operating room by our trauma surgeons, and they have exposed the kidney and show us a bullet, going through one of the poles. And we've, in the past, if there's no active bleeding, potentially put a few stitches, or if there's no bleeding at all, we just reinforce it with some momentum around the area, or close gerodas again, and leave it alone. We don't explore that kidney, especially if there's no urine leak or no active bleeding seen. Sometimes for the stab wounds, we've maybe put some bigger sutures in, and maybe a bolster dressing to keep that area from breaking down and bleeding. But that usually can be fixed as long as it's if you can make sure that the urine leak has been sealed off and there's no more bleeding. Dr. Meyer's group, who is Dr. Meyer's very active in IVUmed, he just was in Rwanda, and his group has studied renal trauma in a multi-institutional way. So there's a lot of patient information that got submitted. We were part of that group as well. And he analyzed who needs an intervention for bleeding and who doesn't, which is very important when the person first comes into the operating room. And he found that he came up with that nomogram. And that nomogram is kind of helpful to see whether or not someone is at really high risk of needing an intervention. You can see here the final outcome is risk of bleeding intervention. And the patient basically in that nomogram accumulates points, and different things are weighted differently. So trauma mechanism, blunt versus penetrating. Penetrating has a higher risk of bleeding intervention. If the patient is in shock, if they have other injuries, and then if they have active bleeding, if there is a really large or if there's a perirenal hematoma, and then the size of it matters. So if it's greater than 3.5 centimeters on the CT scan, then usually the risk of bleeding is quite high. So the larger that hematoma, the higher the risk of needing an intervention. So it's quite helpful, but again, based on CT imaging. So maybe not, for some facilities where there's no CT scan, and I think that the only things that you could figure out is blunt versus penetrating, shock versus yes, no, and concomitant injuries. And then the rest, the extravasation, active bleeding, and the renal hematoma size cannot be established. Please let me know if you have any questions. So how does an angioembolization look like? I alluded to that earlier a few times, and it's used a lot for active bleeding. And that's what we usually mean by interventions. Either the patient goes to the interventional radiologist, or they go to the operating room to get their kidney explored, which leads to a really high rate of kidney removal or nephrectomy. So AB, you see that the first thing that the interventional radiologists do is they squirt contrast into the arterial system, and they look for where there's leaking of that contrast out of the vascular system to diagnose where the active bleeding is. And that's done by an angiogram. And then the embolization happens where they then put little gel foam or coils into the vessels, and they try to do that very selectively. They can embolize the entire kidney, but they try to go very close to where the bleeding is and then only occlude that vessel, because then the rest of that kidney that gets supplied by that vessel doesn't get any more perfusion. So it's important to kind of do that highly selectively. And they're quite successful in stopping bleeding that way. But sometimes, even with the embolization, or the patient is, not stable, or embolization has failed, the patient still needs to get a renal exploration. And most of the time, our trauma surgeons are involved in that. But if you had to explore a kidney yourself, we usually go medial to the inferior mesenteric vein that you can see right here. So that's a good landmark. And then we open on the major vessels to get control of the renal hilum. And if it's a injury where you're very worried about bleeding, that's definitely the right approach. We have in the past also not controlled the hilum and reflected the colon, and then mobilized the kidney and held the kidney in a way, or put a clamp on it to kind of try to reduce the bleeding at the time of the exploration, which is doable as well, especially if the injury is located at one of the poles of the kidney, where you kind of are reassured that you can compress the kidney above the injury to get bleeding control. So that hilar control is not necessarily needed for all cases. And then once you, like this, for example, the upper pole is kind of destroyed, there's bleeding, you want to debride it and make sure that there is healthy renal tissue around. This picture here shows that there's almost like a hemi-nephrectomy that's done. And then you oversew the collecting system and eventually close the parenchyma. We would probably put a bolster in here, like a little roll of some thrombotic agent that we use, and then put large stitches around to kind of keep it in place. But as we know, many times exploration then leads to nephrectomy, and it's part of the assessment that you do in the operating room to see if you can still fix the kidney. And in this case, there was a renal vein avulsion from the inferior vena cava, so impossible to repair that kind of vein injury, and the kidney needed to be removed. Even though if you look at the parenchyma, if the vasculature was still intact, you could imagine, if the collecting system is mostly in the lower pole, you could imagine doing a heminephrectomy, oversewing the collecting system in that area and then closing it. But for this patient, that was not possible because of that vein injury. So what are some long-term complications? This is one of my last slides is hypertension. The patient actually can present during the acute phase in initial hospitalization with high blood pressure. And that can be due to compression of that kidney. It's called page kidney. And that's mediated by renin excretion. So there's not a lot of blood supply to that kidney, and therefore the renin goes up and the blood pressure goes up that way. Very rarely, we have to relieve that compression of that kidney by taking the patient to the operating room and then opening Geroda's fascia and taking out that blood clot. But usually it's very rare. Chronically, the patient, of course, can lose kidney function because of ischemia, as we saw in the grade 4 segmental injury or the grade 5 complete devascularized kidney. It's called gold blood kidney, where there's an arterial thrombus or stenosis. And then there can be fistula formation as well. So usually when the patient leaves the hospital and has a known laceration of the kidney, we tell them, if you get blood in the urine within the next 2-3 weeks, come back in, because you may have developed that AV fistula that can cause significant bleeding and can be life-threatening. So when patients get hematuria or blood in the urine down after their injury within the next month, we tell them that they need to come back. That's all I have. I think we're also kind of out of time, but I would love to hear from you how you get involved, or if you get involved in your renal trauma cases that come to your hospital, and what you usually, how you usually assess the injury. And then I would love to know if you sometimes observe and or if most of the time you do a renal exploration. And thank you again for having me and taking the time to come here.
Thank you very much, Dr. Judith, for your presentation. This is very interesting. I even have one question. You talked about when you have the urine leak, let's say in the upper pole, you can see some extravasation of urine. You can, yes, put a GG stent and a urinary catheter. So how long are you going to keep that in?
Very good question, Galina. Usually for about 4 weeks. 4 weeks for the stent and the catheter kind of as well. We usually take the patient back. If you didn't have a CT scan option, you would take the patient back to the operating room and then put a little contrast up their ureter again to see if it has healed. We don't know exactly when the injury will heal. Is it 2 weeks? Is it 4 weeks? But I think staying on that 4-week time is maybe a good idea, to just not take the patient to the operating room that much. But usually we keep the stent at least for 4 weeks.
Okay, the stent and the urinary catheter,
right.
The urethral catheter. So.
Sometimes we've tried to take the urinary catheter out because it's very bothersome for the patient. But in my experience, what can happen is they have bacteria in their bladder due to the catheter. You take it out and now they reflux up into the kidney because they have a stent. And with a stent, we always see reflux. And now if the injury hasn't healed, they may then develop a kidney infection, pyelonephritis, or an infected urinoma. So I think it's better to make sure that the kidney has healed before you take out that urinary catheter.
Right. Thank you.
Absolutely.
I think we have some colleagues asking questions. Dr. Samba, detected.
Yes, I just see here. So are we using the AST classification for renal trauma? Absolutely, all the time. Yeah. We communicate like that, because if my team gets a call for renal trauma and most of the patients, as I said, have a CT scan, so that injury is then staged and graded. And then if the trainee comes to me and says, I have a grade 3 renal injury, I know what they're talking about and how serious the injury is. If they have a grade 4 or 5, I definitely need to make sure, is it vascular, devascularized, or is it that segmental infarct? Because that's very different. We usually don't even get follow-up imaging on those patients because they lost their kidney, yes, or part of the kidney function, but in the acute hospitalization, that doesn't affect them. They have a healthy other kidney usually. So I think that then I need to make sure that the trainee understands a segmental injury is very different from a active bleeding kidney. But usually we understand very well when someone says, I saw a grade 3 injury or 2 injury, they're in the emergency room, it doesn't look like it's bleeding. We say the patient can go back home.
So you don't keep them overnight, like observe if they're hemodynamically stable? No, you don't need to do that?
Right. Usually not with those very low grade injuries. But if they are grade 3, I would probably say let's observe, make sure their hematocrit stays stable. And then of course, grade 4s and 5s, we need to be diligent, maybe even re-scan them. Galina, do you have a CT scanner in your hospital?
Yes, we have a CT scan, and most of the patients that we have who get a renal trauma, it's blunt renal trauma most of the time. If it's penetrating, we don't really have to do a CT scan. We never do a CT scan for penetrating trauma. They always end up in the OR and get a nephrectomy done. Unfortunately, we don't do the IVP test because maybe there is no serum to confirm if the contralateral kidney is working. So we just palpate, feel the kidney is there, and proceed with the nephrectomy. And for blunt trauma, now we use the AST classification, and most of the time we observe that we never send them home, even if it's grade 2. We keep them and observe like for 24 hours. If they're hemodynamically stable and hematocrit is still normal, then we can let them go home and come for regular follow-up.
Right. So you don't observe them for very long, just a short amount of time.
No, just yes.
Yeah.
Especially
perfect.
to make sure that they stay like hemodynamical, the stability is really acquired and the hematocrit.
I think that's absolutely reasonable. Yeah. To absorb them for a tiny bit. Yeah. Before, I think all of the renal trauma was admitted. They even went to the intensive care unit, but we know now that, that's too much. We don't have to do that.
Right.
And do you have?
So I have my. Sure. Yes, we have. We do the stenting. Yes, we have the stents. We do the stenting, but unless I think one or two cases have been managed by stenting, but the rest we just observe really. They come back. If they come back and we do, most of the time the patients that we stent are the ones who had got a second CT scan, showing that the urine leak
is still leaking,
like increasing. Yes. For those ones, we can do the stenting. Others, we mainly observe, keep monitoring, keeping. Yeah.
Right. Yeah.
I have my colleague, he's the other urologist, Dr. Reveria, who is also there.
Oh, yeah, I see that.
Yeah, he's a urologist in Burundi as well.
Great. And the question is how long we leave the JJ stent in place?
So it's 6 weeks. It's I just keep the normal 6 weeks.
Sure.
But now the only issue I had is the catheter as well, keeping the catheter in place for that time.
For that long, right? Yeah. It's
for that long, exactly. Yes, yes.
It's tempting to take it out because the patient is so bothered usually. But I think that it doesn't make sense to take out the urethral catheter and have them then reflux up into the kidney. Then it's better, I think, to take that stent out too, you know? And I think usually I err toward maybe 4 weeks, but you know, it's 4 to 6 weeks. I don't think we have studied that yet. You know, it would be really cool to study, you know, you stent all of them and kind of image them at 1 week, at 2 weeks, at 3 weeks, and see when those injuries heal. We just arbitrarily pick 4 to 6 weeks because, you know, that's what we hope then, you know, most of them are healed. But I've had people that have prolonged leaks that even after 6 weeks are not healed yet. And then you keep the catheter in, you keep their stent in. Rarely they need a nephrostomy tube to just optimize the draining. But that's rare, but it has happened. And then usually what we do is, you know, take the catheter out, and we know that they're doing well because they get a fever, flank pain with having the catheter. So we have to put the catheter back in and leave the stent in for longer. And they have quite the protracted long healing phase, which is hard on the patient because they keep on having their stent, and maybe the stent even, you know, after some time needs to be replaced, and eventually they heal. But I think it depends all about how badly that collecting system was injured. And it could even lead to sometimes needing to remove the kidney just because it doesn't heal.
So for your follow-up, do you regularly do some ultrasound to follow up if the urine leak has reduced? What imaging will you do to decide if it's time to reduce the catheter, to remove the catheter, or to wait for a little bit more? Do you still use the CT scan, or you can just use the ultrasound and see?
And Galina, is that for patients with a stent?
Yes, patient with a stent, yes.
I think that the ultrasound doesn't show enough because it can't show us if there is a urine leak still. So the two options, I think, are CT with contrast or taking them to the operating room and putting some contrast in their ureter. And either one is okay. Yeah, if they get close to where they need a catheter change or their stent needs to be replaced or something, then I take them to the operating room. But otherwise, I think a CT scan with contrast would be okay too, just to see if their leak has healed.
Right. Thank you very much.
Thank you. I get the little, yeah. Ah, I see. So there was a comment on that the stents are kept in for 3 months. You know, not a bad option either. I wonder, I would love to know how long you leave the urethral catheter. Because 3 months would be a long time.
A long time, long time, really. Patients will be complaining a lot.
Yeah, right. The 3 months, you know, I think that's how long we usually leave stents, and then we need to remove them anyway. I can get that, but I think without a urethral catheter, then they would have reflux, right? The urine from the bladder when they pee goes up into that collecting system, which is not great because you kind of want to have it all drain. You don't want to have it reflux up and then put pressure on your healing segment.
Mm-hmm. Yeah, great. It's understandable, really. Otherwise, you will be producing another urine leakage if there is reflux and yes.
Yeah.
All right. Thank
Galina,
you very
very
much.
nice to meet you. Very nice to meet everyone.
Yeah.
Thank you so much, Dr. Hagedorn and Galina, for joining us. So good to see both of you.
I hope I can visit someday.
Yes.
Or you come visit us.
You're most welcome.
Yeah.
Thank you.
You.
Bye.
Bye.